We are just about to start the first ESSM Workshop webinar. So welcome everybody who's logging on. We'll give it just 1 or 2 more minutes to allow people to log on, and we'll be ready to start. You see, we have now 50 participants. It's very nice. In a minute or so, we start the session. Okay, welcome everybody. I'm very excited. I've been looking forward to introducing this for a long time now. My name is Mikkel Fode. I'm the chairman of the educational committee of the ESSM. And moving up to our virtual congress in a few months, we have organized workshop webinars. These are similar to the statement webinars we've done already, but these are based on the ESSM workshops, which we will not have time for during our virtual event this year. So it's very exciting to me to present the first one on the sexual consequences of gynecological surgeries with the pre and post counseling. And this is going to be with Gabrijela Simetinger and Johannes Bitzer. So it's a very exciting session that we are in front of. Please also note that we have a few more workshops lined up already on sexual and relationship in long-term couples and paraphilic disorders coming up in November and December. So remember to also sign up for those. And as I said to begin with, this is all leading up to the ESSM virtual event that we will do this or in 2021 instead of the Congress, obviously due to the COVID. And this is going to be between the 19th and 20th of February. So please note it and do sign up for this. It's also my pleasure to give the word to our scientific chair, Giovanni Corona, for a few introductory words. Giovanni.
Thank you, Mikkel. I think that, as you said, we are going to initiate a very, very interesting session. I think this one is one of most neglected topic of sexual medicines, but I'm sure that the two outstanding speakers that are going to address this issue will give you some more and more important clinical suggestions on how to manage this situation. This is the first one of very, very interesting workshop. So I really thank the educational committee and Mikkel for their hard work. And I'm sure that you can enjoy this workshop as well as the coming other workshop, as well as our webinar web congress in February 2021. So enjoy the session.
Great, Giovanni. And just during this session, for all of the attendees, please be sure to have your microphones muted. And then if you have any questions going along, these can be posted pushing the Q&A button that you'll see on the Zoom screen. I'll collect the questions and we'll have the speakers answer them at the end of the session. And now I give the word to our president, Carlo Bitocchi, for also a few introductory words. Carlo.
Thank you very much, Mikkel. I'm very pleased really to start this new series of our webinars after the other that we have done before summertime. And to do so, I would like really to thank, if you can move on the next slide, Mikkel, please, these two persons that you have already listened to, and they're really the key points and the secret of these webinars, because Mikkel has been able to organize all of these and other things in the educational program, and Giovanni is really the person that is looking after all the scientific contents of our society. So really, thank you very much from the bottom of my heart for these two persons for what they are doing for our society. If we move on the next one, I really would like to take a few minutes, no more than 2-3 minutes, just to introduce you other important educational programs that we are running in our society. You know, this year we have a little bit of problem, like everywhere in the world, due to the COVID situation, but we are ready to launch in the next year again, as every year, the ESSM School of Sexual Medicine and also the ESSM Advanced course on Sexual Medicine. And they will be hosted in Budapest as usual, and the period will be 9th to 18th of April. As you know, the participant of the ESSM School of Sexual Medicine will have the opportunity to learn and to discuss with the expert people that will be there the essentials of sexuality that are necessary for the best clinical practice. We have started also the advanced course that is mainly dedicated to the more experienced scientists in this field. And we are very sure that this program will be exciting, and usually everybody is joining this school is then became very much attached and member of our society. So all the information and registration are already available on the society website. Please move on because there are a limited number of participant possibilities. Another important point that I want to introduce you that will start in 2021 is a completely new program, and this is dedicated for surgeons, is the ESSM Academy on Genital Surgery. And this is a complete learning and hands-on training program that is designed to improve knowledge, technical and communicative skills of the surgeons. And basically, it is important also to confirm that they master the novel operation techniques in genital surgery. And this is, of course, according to the European standards of education. And we have 4 different levels for education. Level 1, the base will be on textbook and video library that are already available. Then we will move on a dry lab and 3D model, and passing through the web lab and the cadaver training. Finally, people will be able to be fellow in the best centers of excellence in Europe. So this is a really exciting program that will start in possibly springtime and will finish before the end of the year. And so the announcement will be soon on the website. And also for this project, it is even more selective because there will be less possible position to be taken. So please try to get it as soon as possible. And then one word on our videos. I think they are very important because you can have the best knowledge videos on erectile dysfunction and also surgery. And these videos are already in the website, and it is important because they cover from the basic epidemiology through the diagnostic, finally going to the treatment, not only the medical, but also the surgical treatment. So stay updated on genital surgery and on erectile dysfunction looking at our videos. And finally, our publications, you know already, because I'm sure that some of you or most of you has already the manual of sexual medicine that is also available for the ESSM members on the website. And it is a textbook which covers all the different aspects of the sexual medicine. And it is important because it's the book that we use for preparation of the sexual medicine exam, and the next one will be in Rotterdam in 2022. And the syllabus of clinical sexology is more devoted to the sexologist, and is also available on the website in the textbook, which covers the most important aspect of clinical sexology. And again, this is important for the preparation of the exam. Again, it will be held in Rotterdam 2022. And last but not least, sorry, the textbook on surgery, it's also ready, and it will be unfortunately given the next time that we will be able to have a physical congress, but it will be available soon, probably also on the website. So do not miss the rest of the information. And I think that next slides, this is just the slides that remind you that we will be available for the ESSM virtual event from 19 to 20 of February. And I believe the scientific program is really fantastic. And I think all of you will find some interest session at least to be followed. So please stay tuned and see you possibly also for this event. So thank you very much. And I think finally, I would like to give the word to our fantastic and outstanding presenters and lecturers, are Johan and Gabrijela. They are really very good, and I'm sure that they will run these webinars in the best way and the best also perform in order to increase and make your acknowledgement on clinical practice as much as possible good. So thank you very much, and please keep going.
Thank you. And the first speaker is Professor Johannes Bitzer, a true expert on this topic. Johannes, you're welcome to put on your slides.
Yeah, hello, good evening. I will share my screen.
And again, for everybody, remember to keep your
Can you see? I cannot share my screen.
We see it.
I somehow, what happened?
We see your screen, Johannes. So if you click
you can see my screen?
Yes, okay. So if you click on your presentation and open it.
Oh yeah, sorry.
From there.
Is it okay? Can you see me now?
Yes.
Okay, sorry. Good evening to everybody. And it's a great pleasure for me to be with all the colleagues discussing and working on an issue which is, as Carlo has already mentioned, quite frequently neglected. And I was asked to give a talk on sexual consequences of gynecological surgery. This is my background. As you can see, I'm a little bit an older man, but I'm still working in the department and also in private practice. And I also try to promote science as an associate editor of the Journal of Sexual. If we have a general look on how gynecological surgery can impact sexual health, then we have two major pathways. One pathway is the medical pathway. Of course, surgery can lead to destruction or damage to tissues and organs involved in the sexual response. Surgery can lead to destruction or damage of the autonomous nervous supply and neurovegetative regulation of the sexual response. It can impair the neurovascular and neuromuscular regulation of the sexual response cycle. And finally, it can impair and dysregulate the hormonal regulation of the sexual response cycle. So tissue damage, nerve damage, neuromuscular regulation, and hormonal regulation can all be impaired by gynecological surgery. And in addition to that, surgery, for example, at the vulva, can lead to disfigurement of intimate body parts. So this is the medical pathway. And then we have the psychosocial pathway, which is also very important in the context of gynecological surgery. We have in different situations the emotional response when it comes to cancer, the fear of death, feelings of guilt when you have changes in the genital organs, feelings of shame, feelings of anger, frustration. There is a lot of, a huge fear of losses, losing femininity, losing fertility, losing control, losing youth, losing the partner. And then we have what we call in psychology the response to the operation and to the disease, the search for explanation, the doubts, am I in the right hands, the helplessness, the hopelessness, and also the social image of certain interventions, like, for example, hysterectomy being a sign of being old. Regarding the relationship, this is frequently overlooked, that gynecological surgery can have an impact on the relationship. It may lead to a distancing to the partner, a fear of the partner to be somehow affected by the change of the female partner. and quite a bit of changes in partner dynamics, where you have to redefine a little bit the different roles. Now, this, of course, all works together in what we all know as the biopsychosocial model in sexual medicine, where we can see that sexual well-being, sexual function or dysfunction is determined by medical biological factors, individual psychological factors, relationship factors, but also social factors, including the medical system. I would like to give you a little bit an example about these interactions, taking the example of the hysterectomy, which is a frequent operation, or at least was a frequent operation in gynecology. Here, for example, you can see these different dimensions. Hysterectomy can be experienced as loss of fertility. It may involve tissue destruction involved in sexual function. It may lead to endocrine changes. It may have an impact on body image and gender identity, and it may also impact partner's reaction. This was first described in this famous publication on what was called post-hysterectomy syndrome. I'm trying to show you a little bit the history of this whole issue of gynecological surgery and impact. And in this publication, it was said that hysterectomy, different from other operations, was accompanied by 70% depression, hot flushes, urinary symptoms, extreme tiredness, 50% headaches, dizziness, and insomnia. So here you have a first publication pointing to possible very negative outcomes. A lot of studies followed this primary study. Some of them really were indicating that it's true, hysterectomy deteriorates sexual health. It also deteriorates mental health and increased risk of long-term mental health issues, especially depression and anxiety, by this Mayo Clinic publication. And then, depending a little bit on the design of the study, you found different results. Here again, a negative result. Hysterectomy, even with ovarian conservation, is associated with an increased long-term risk of de novo depression and anxiety, especially when performed in women who are younger. This was an important group of researchers, retrospective comparative studies with matched control groups. And then things changed a little bit, and you get in the field of prospective studies, taking clinical examples, including the diagnosis for which the hysterectomy was performed. This is the famous 2-year prospective study, Maryland's Women's Health Study. Important conclusion: sexual functioning improved after all, overall after hysterectomy. Sexual frequency, activity increased, and sexual dysfunction even decreased. So the controversy went on, and you know what happens then is that people try to do some sort of meta-analysis, and here you find this publication which came to the conclusion that for about 20% of women, deteriorated sexual function has been reported, and current research is attempting to identify mechanisms and predictive factors explaining these post-operative changes. Now, this was an important step. It was not only doing studies to see what the outcome is, but also the focus was much more now on the factors that contribute to a deterioration of sexual health in those women affected by these changes. You understand it. Is it hormones? Is it the operation technique, etc.? And here you can see in this Cindy Maston's overview and Andrea Bradford, they were looking at the multifactorial model. What is the impact? Is it the surgical approach? Is it the removal of the cervix? Is it the HRT hysterectomy? Is it the preoperative menopausal status, etc., 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 where people were looking now into the different possible contributing factors which would explain why in an individual woman sexual health would be impaired. So what finally was people were really looking into it and are still looking into it is, if you want to do a good study, you look at the time before the operation, the pre-existing sexual health, mental health, physical health, symptoms related to uterine disease, endocrine situation, sensitivity to region preoperatively and relationship preoperatively, and then time after operation, you again measure all these parameters to see the changes. Now, just to show you a little bit in the field of oncology that the research into the different factors, is it surgery, is it hormones, is it age, can come to quite controversial results. Here you can see when it comes to vulvar cancer, something that people were expecting, that arousal and orgasmic disorder linked to the extent of the excision. 30% stopped their sexual activity. So here just the fact of tissue destruction was very important. In other studies, it was shown that it is more the changes in body image and not the extent of the operation. So finally, what we are really interested in and what we are going to discuss today is mainly what is the individual response? How can we help to assist women in the decision-making regarding gynecological operations, but also in coping with gynecological operations? And what research has shown that the final outcome, whether there is an improvement in sexual function or a deterioration in sexual function, actually depends on 4 factors. One is the pre-existing sexual health. It could be shown that women who have a good sexual activity, good sexual health, are less prone to negative outcomes. Sexual difficulties, but also sexual resources are important. Then the impact of the surgery with the 5 domains I mentioned. Then the individual coping with the outcome of the operation and the coping of the couple and the family. What do I mean by this? Individual pre-existing factors are, as I mentioned before, was the person very active? Was she very satisfied with her sexuality, or did she already suffer from dysfunction? How stable is the body image? What is the age? And what is the general well-being? So all these factors contribute to the outcome. To the outcome, as I mentioned before, these 5 parameters play an important role regarding the surgery. What does the surgery do to the organs, to the autonomous nervous system, to the hormonal regulation, and to the body parts? The third domain is the psychological adaptation, the coping. Is the person able to adapt to the change? Are there affective disorders like depression going on? We call this resilience. How are people trained, or how are people capable to cope with changes, and also the changes in the partner dynamics? So finally, when we understand how the outcome, the different outcomes influence the sexual health after gynecological surgery, the question now is, how can we help? And I think it's step by step that, first of all, regarding the pre-existing sexual health, sexual difficulties, and sexual resources, we should really proactively ask about sexual well-being and proactively ask about expected fears regarding sexuality. very often, and we will see that in the second part of our workshop, these questions are not asked. So I think it is important to assess the expectations and concerns of the patient regarding the operation with respect also to sexuality and identity. How do you feel about losing the uterus? Do you think it has a negative impact on how you feel as a woman? You know that you will not be able to get pregnant anymore, apart from rational argument. What does that mean emotionally to you? I think we should empower patients by explaining in detail the anatomy and physiology, for example, of the uterus. Discuss the expected positive outcomes and discuss also the possible changes in mood and sexuality, and that it is very important that we talk about it also afterwards, that the majority of women can adapt quite well, but that it is important already to understand now whether you feel frequently depressed or anxious, and whether you have any sexual problems like low desire, pain, or difficulty to get aroused in the past. The second domain where we have an influence is, of course, the surgical technique. It's the indication, it's a laparoscopy, nerve sparing intervention as minimal as possible, and preservation of organs. And the third domain is about helping the patients to cope with the outcome. Ask about satisfaction with the operation, ask proactively about physical, mental, or sexual side effects. If the patient reports sexual problems, assess the type of problems, desire, arousal, pain. Look for possible hormonal factors, look for individual psychological factors and relationship factors. And we can contribute to help to adapting to this phase, for example, by discussing the application of hormones, testosterone, estrogen, by doing basic sexual counseling, and if necessary, sexual therapy. And finally, what is frequently overlooked is the importance of the partner. I think it is worthwhile after the operation to invite the partner to discuss the diagnosis, treatment, and outcome with the patient and the partner, to help them, what we call in psychology the empowerment, so that they understand what happened to them and what the impact is. And then also to find out what does the couple want, what would they want to achieve now with the operation, a maximal restitution of pre-existing sexuality, or in some cases like more the oncological operations, rehabilitation, establish a new sexuality, what has to change, what should stay like this, like it is, and what are the concerns and possible barriers. With this discussion, we open the floor also so that patients who do have problems afterwards know that they can come back and that you can talk about the problems and can talk about help. Well, I just wanted to give you an overview, and I thank you very much for your attention.
Thank you, Johannes, for your excellent presentation. Now we give the word to our second speaker, Gabrijela Simetinger, who is, Johannes, if you stop sharing the screen, I think
yeah,
it's needed. Thank you. Who is one of the members of the educational committee of the ESSM, to give the second half of this workshop. And then following this, Johannes, I think you need to, can you stop sharing?
I stopped it. I stopped sharing my screen.
Gabby, are you able to share yours?
No.
Now it looks right.
It looks okay.
And please remember, yes, thank you. And please remember, everybody, to ask your questions in in the chat box. I'll collect them and we'll try to answer them at the end of the webinar. Gabby, please.
Thank you for the invitation. I have the second part of the workshop, Sexual Consequences of Gynecological Surgery, Pre and Post Counseling. My presentation is based on my clinical experience. I worked in Slovenia. I shall tackle the cases of gynecological counseling that demanded further sexological assessment. I shall present two types of cases, cases where women needed psychoeducation and counseling, and cases where women needed therapy due to sexual dysfunction. My most frequent observation: women do not get information on sexual encounters and sexual function after operation. Women receive inaccurate information about that, like you should not have sex until your first post-operation examination. Women receive false information, like no sex after vaginal hysterectomy, but they could have oral sex, or sometimes women also receive judgmental information. The sexual dysfunction that I observed after gynecological surgery and procedures are painful sexual intercourse, dyspareunia, sexual aversion, low sexual desire, or orgasmic dysfunction. My first question is, why do you think gynecologists do not talk about sex? First, it's not important to them. B, they do not have enough knowledge. And C, they do not have enough time. Please vote.
I see you're all still voting. Let's just wait a few seconds before I end the polling.
You answer, they don't have enough knowledge. Thank you for your answer. I don't know why, but I just want to know what you think. Let's go further. I can't go further. What's wrong? My presentation is stopped.
Gabby, try to unshare and then share the screen again.
Okay.
All right, sorry about that.
Okay. Knowledge and skills of gynecologists. The majority of gynecologists really do not have any psychosexual education. According to research, why don't professionals talk about sex? They feel fear about opening up a can of worms. They lack of time, resources, and training. They concern about knowledge and abilities. They worry about causing offense or personal discomfort. They are lack of awareness about sexual issues, and some of them feel discomfort related to sexuality of the opposite gender, Black and ethnic minority groups, older and non-heterosexual service users, and those with intellectual disabilities. Probably gynecologists share the same problem. About taking sexual history, I observed that gynecologists don't take sexual history. Sexual history is not taken adequately. If they do ask, they do not address sexual problems in the past. What about beliefs and opinion? The biggest problem is that when gynecologists have a lot of misconceptions, if they moralize about promiscuous sexual behavior because women had more than one sexual problems in their life, sexual partners in their lives, they have a lot of prejudice about patient's sexual life and experience. They prevails maltreatment, malevolence instead of benevolence. They have basic lack of support due to their beliefs and opinions. And gynecologists usually explain only changing sexual partner may bring about HPV infection, and they don't explain that only risky sexual intercourse, that one risky sexual intercourse is enough to get infected. Don't explain that there is a possibility that she got infected because her partner had risky sexual conduct or with one or several persons. Let's move to the cases. First case, false beliefs and opinions, is Mia, 31 years old. She came because of low sexual desire. She's a dance teacher. For more than 4 years, she had a pathological pap smear. The gynecologist accused her promiscuous sexual behavior, and she believed them. She was told she got infected because she changed sexual partners. After the large loop excision transformation zone, she experienced problems. She persistently rejects sexual intercourse for 6 months because of fear of HPV reinfection. She has been she has been with her current partner for a year, and that's why she doesn't want to talk about that with her partner. But I did just psychoeducation and counseling, which helped her to feel better. The second case is Tina. She's 26 years old. She had LEDs in the local anesthesia 8 years ago. The procedure severely interfered with her psyche. She experienced the body position she was put during the procedure as invasion of privacy. The male gynecologist was not nice to her. He made biased remarks about her sexual life. After the procedure, she relived the scene during the sexual intercourse with her boyfriend, and because of that, she got aversion to sex. She was appointed to a psychiatrist, but 2 years later, she had to reoperate. The procedure was done by gynecologists she trusts. Before the procedure, she had 2 panic attacks. Panic attacks began to repeat before every sexual intercourse. She attends psychotherapy with psychiatrist sexologist, and her psychiatrist sexologist sent her to me because she couldn't stand any gynecological examination. She broke with her partner, and my job is just to prepare her for gynecological examination and successful take a pap smear, because she has a persistent HPV infection. And the third case is Anna. She came to assessment due to pelvic pain and dyspareunia. She had her first laparoscopy 6 years ago and her second partner at the time. She was diagnosed with a pelvic inflammatory disease. Pelvic pain and dyspareunia began after laparoscopy. And gynecologist also told her, you had pelvic inflammatory disease because you often change sexual partners. The second questions: what will you do first? Gynecological examination, take sexual history, psychoeducation, counseling, sensate focus, or relaxation techniques?
Again, let's just wait a few seconds so that we collect as many answers as possible. I will share the results shortly.
Yes, the answer is right. We should take first take sexual history. After the biopsychosocial assessment, among the predisposing factors, I found that she had a very difficult childhood. Mother died due to the cancer. She had depression in the past and anxiety attacks, and she was sexually abused. The laparoscopic surgery with the laparoscopic surgery, start painful intercourse, aversion to sex, and she got stay without sexual desire. In conclusion, gynecologist has accused Anna and moralized about her sexual behavior, but this accusation that she has had more than one sexual partner in her life precipitates sexual dysfunction. During the third session, Anna confessed she was sexually abused in the childhood, and she believes that she is responsible for the things that happened to her in the past. The next case, lack of knowledge in sexual medicine. It's Julia. Endometriosis was confirmed in her youth. She gave birth once. At the age of 45, she had hysterectomy because of pelvic pain and dyspareunia. Gynecology promised her unpainful sex after operation. She has acupuncture, but every sexual intercourse is still more and more painful. After the biopsychosocial assessment, she has pelvic pain syndrome. Psychologically, she's a perfectionist. She's all the time under distress. She's the owner of the restaurant on lease. She lived for 5 years with her mother and provided care for her. She is 20 years with her partner and she completely stopped masturbating. The gynecological examination has shown that dyspareunia persists due to the hypertonic pelvic floor, and my therapy involves relaxation therapy techniques, mindfulness, body awareness technique, and sensate focus. The case with the women didn't get any information. Dalia, 41, 4 years ago, she had tension-free vaginal tape due to stress incontinence. After the procedure, they followed the complication, erosion of the tape through vaginal mucosa. After the reoperation, she doesn't feel anything during vaginal intercourse. She had less sensitivity of area under the urethra. After the operation, she feels vaginal laxity. She said, my vagina is too big, and she doesn't climax anymore. She doesn't know what to do. Many gynecologists claim that her problems is not linked with operation. After biopsychosocial sexual assessment, followed psychoeducation, explanation of the anatomy and physiology of sexual response, TVT procedure, explanation, sex after the procedure, explanation about vaginal laxity and that her vagina is healthy, My counseling then again involves masturbation, sensate focus, body awareness technique, but she was happy that I believed her, and this was enough for her. And the last case is Maria, 60 years, 22 years ago, at the age of 38, she had hysterectomy with adnexectomy, and she received estrogen injections for 9 years. During the sexual assessment, I found out that she had no sexual intercourse before marriage. She had vaginismus for a few months immediately after marriage. Later, for some years, she was fine and gave birth to 2 children. But after the second birth, she had dyspareunia. She never masturbated in her life. And due to dyspareunia, she was advised to have hysterectomy. 22 years after hysterectomy, she came to therapy due to dyspareunia. After the biopsychosocial assessment, I found out that she had arthritis, frequent colpitis, psychological problem with the body image, feels shame in the front of her partner, and socially her son died. He had a cancer. The gynecological examination showed ragade perineum, lichen planus, and hypertonic pelvic floor. The therapy was local corticosteroids, and we did sexual therapy. Conclusions: the accusation that women had more than one sexual partner in their life are the most painful and disturbing for the patients. Sexual dysfunction is not a result of acquired false information. False information is usually a precipitating factors, and the majority of the patients are reassured and satisfied with proper counseling. And gynecological in my country definitely needs basic knowledge of sexual medicine and how to take sexual history. Thank you for attention.
Thank you very much, Gabby. Another excellent presentation, and I think especially important with these cases to see it more concretely. We have a few questions here that maybe the both of you can try to answer. The first one is for you, Gabrijela. What body awareness techniques do you use?
The shower, a lot of time the shower, and we use the how to take the shower, and she has to explore the body and explore the body. Sometimes we body mapping, depends what the kind of problems women had that she learned. What is not unpleasant for her, which part is unpleasant, which part is on which part she feels good, and then she has to work on the unpleasant part that becomes not so unpleasant, and then that started to enjoy in this, also touching this part of the body.
Maybe I can add that sometimes it's quite helpful to ask women to make a drawing of her body and
Yes.
thus a little bit better understand what the inner representation is of the body, how is the image, and then you can also a little bit work with this visualization sometimes.
Excellent, thank you. I think this one was posed for Johannes, but maybe it's for the both of you. How common are the impairments due to gynecological surgery? For example, loss of sensitivity. Johannes, if you want to start.
Yeah, this is especially the work of Cindy Meston, who tried to find out if there is really changes in very individual changes regarding the individual differences in sensitivity to issues, to body parts. You know that not all the women have the same eretogenic zones. Not all the women have the same parts of the body where they are sensitive to sexual stimuli. And so, in fact, there may be differences in responding to the same operation, depending on how much of how the individual difference in sensitivity to stimulation was.
Do you have anything further to add, Gabrijela?
No, I just want to say that this this kind of problems. It's after radiotherapy. Radiotherapy is more often to see than after the fissional surgery. They sometimes they just feel that is a loss of sensitivity, but when they started to work on the body, they could learn to have the same sensation also in this part, you know, after the official surgery. But after the radiotherapy, it's could be a problem.
All right. Another question that could be for the both of you that was posed twice. Is there any difference between a total and a subtotal hysterectomy with respect to sexual dysfunction?
Well, I think there is now good evidence with different studies, especially with the prospective ones that I mentioned and with the systematic reviews, that there seems to be no difference. Initially, some studies in Scandinavian countries have indicated that you have less impairment with supravaginal hysterectomy. In my practice, I noticed that when I discuss hysterectomy for benign reasons, which is very rare, but which sometimes occurs, I give the option to the patient whether she wants a subtotal or a total hysterectomy, giving the procedures, the advantage of total to avoid any cervical problems, but the possible disadvantage that a total hysterectomy may be considered as something more radical. And I realized that some of my patients really wanted to keep some part of the uterus and preferred to take out only the part diseased, which in that case were severe fibromas or something, which was in the corpus. The cervix was healthy, and they wanted to maintain, to keep the cervix, even acknowledging that they have to come for cervical screening.
Do you feel from your experience, obviously the publications may not be there, that there may be some psychological benefit to do a total hysterectomy?
Yeah, but I think it is the right of the patient to understand and also decide about the procedure. I mean, to solve the problem of heavy menstrual bleeding with severe submucous fibroma, which you cannot treat otherwise, and where the woman is really very much stressed. It is, I think, a good practice to say, to resolve this problem, we need to take out the corpus part of the uterus, because this is where the submucous fibromas are, or even, of course, you do uterus preserving surgery by hysteroscopic interventions, but sometimes this is not possible. So I think there is a tendency now in many women, and I think it's okay that they say, I want to I want to limit interventions on my body to the necessary interventions to solve the problem.
And Gabby, you were nodding. Do you have anything to add, or do you agree?
I agree completely. Yeah.
Excellent.
Mm-hmm.
We had another a very specific question about a patient. Of course, this is difficult, so you'll have to answer in general terms. But somebody's asking, one of my patients after radiation for cervical cancer had scarring and the inability to have sex. Now her husband was very depressed, and she did not know how to help him. So how to deal with this couple, both her and the consequences for the couple and the husband's condition, I guess.
I think it's, if I may, just because I got this question before in the mail, I was a bit surprised, but maybe not surprised. Obviously, in many places and countries, women after radiotherapy are not sent to a special oncological nurse who will discuss with them vaginal dilatation techniques. I mean, there is a scarring and there is a shortening, but you can improve that situation if you start with a dilatation therapy early after the operation. And in our institution, if possible, the partner is involved. The partner should understand what is going on. This may restore the capability of the patient to have penetration and to enjoy penetration. If it is not possible and penetration is not possible and the partner feels frustrated about it, I mean, it's like Gabrijela has said, it's sexual counseling that penetrative sex is only, I always say 20% of sex.
We have the same issues and the same ideas after prostate cancer surgery, I'll say. So I think this is universal, that the idea maybe is too narrow. So with that, to be able to end this on time, I'd like to really thank our two speakers, and I believe that these really are two of the great educators of the ESSM, and they contribute very, very much to our association. And I think to me, this was reflected in tonight's webinar. I also want to thank our president, Carlo Bitocchi, and the scientific chair, Giovanni Corona, for the efforts in arranging and supporting these webinars. And of course, we have to thank Daniela Payola from the ESSM office. You heard her a couple of times with the polls for all the arrangements. I think nothing in the ESSM would be possible without Danny. And finally, I was saying the biggest thanks to the participants making this a success. Remember to consult the ESSM website and sign up for the next webinar on sexual pleasure and cohesion in long-term relationships with Charmaine Borg and Marike David. Thank you, everybody, for participating.
Thank you very much.
Good night.
Good night, everybody.
Congratulations. Bye-bye.